I'm really, really grateful to be here and especially learn together with you today. As we get started today, I want to begin by remembering that we are on a lonely land. And as we care for families who are newly arrived to the US, it's important that we also remember that we are on, those folks have been displaced from their ancestral land, and we're able to do that and care for people by being on the land that other people have been displaced from their ancestral land. So the two are interrelated. We do need to make sure that we are upholding and uplifting Indigenous communities as we do this work. And I'll share with you in a moment a really powerful question that an elder had once asked me. It would be harmful if we didn't acknowledge how many people are hurting in the world right now. There are so many conflicts happening around the world. There are so many people who are displaced, who are scared, particularly women, children, and people with uteruses. And so as we do this presentation, we can hold them in our hearts. And for those of you that may be affected, if you need to take a moment at any time during this presentation, please do. So I have nothing to disclose in terms of financial disclosures. All of the grants that I've received are operational support. But I do have a personal disclosure in that this work really begins in my own ancestry. My family came to Canada, which is where I joined Stanford from, as refugees. This is a picture of a similar family because I actually couldn't find a picture of my own family, but I did find their paper slips that my grandfather had kept that really were just this little slip of paper that said refugee on it when they came in. I like to share this because sometimes when folks are talking about the children of refugees, I'll say, well, that's me. I'm the first person in my family to be born in Canada, and the first of a lot of things. But what I'm not the first in, because of the community that I come from, is mutual aid and collaborative work and community engagement. That is really something that is part and parcel to my own community, partly because we have experienced many waves of refugees coming from all over the world, most recently Afghanistan and Syria. And I like to think about how different my life would be if it weren't for certain policies that were in place at that time that allowed my parents to come as resettled refugees. But one of the time, remember I said I'd come back to this, but an Indigenous elder once asked me, he said, would your parents have considered Canada a place of safety had they known how the Canadian government had treated Indigenous people? And it's always caught me off guard and made me pause to reflect because I actually don't know if that's true. But when people ask what's inspired me to do this kind of work, it's really just in my own stories and my own family upbringing. Today, I'm hoping we'll understand a little bit about the process and epidemiology of migration to the US, including some geopolitical considerations, but we are not going to become history or political experts. And I hope that you can develop what I call a clear approach to caring for adolescents, women, and birthing people who newly arrive in the US. I'm hoping you'll find a little nugget of a way to meaningfully respond to social determinants of health in your clinical practice and identify new opportunities for partnerships that can contribute to improving health outcomes across research, advocacy, clinical work, and education. So I'm going to start by saying this is an aspirational talk. As we talk about things, I'm going to invite you to dream and envision about the best possible future for your patients here in the US. So first, I want to talk a little bit about terminology. We hear the words immigrant, migrant, refugee, asylum seeker, undocumented. What does that mean, and are they all the same? The answer is no, they're not all the same, and it's really important that we take a little bit of time to understand the differences because that leads to different resources that families can access. So a migrant, actually, there's no set definition. It's anyone who is living outside of their country of origin for any reason. It could be economic reasons, it could be work reasons, it could be school reasons. It also includes people who are immigrants, people who have permanent status in their new home, So this would be permanent residents or family, folks who have family reunification. It includes refugees, asylum seekers, and people who are living without status here, but are still living outside of their country of birth. So let's explore what it means to be a refugee and an asylum seeker a little bit more, because that's the terms that we often hear. I have been giving a talk like this for years now, and every time I give this talk, I say, this is the record year for displacement. And I'm this UN Global Trends report comes out every 2 years. And I am sure the 2025 report will have this number be even higher. There are 110 million people who are forcibly displaced. And you can see it distinguishes between people who are refugees, people who are internally displaced, which are the majority, and asylum seekers. So what is a refugee? A refugee is someone who is outside of their country of origin and has a well-founded fear of being persecuted based on race, religion, nationality, or social group. And that's a very set definition in international law that comes from the Geneva Convention of 1951. Resettled refugees are people who are the people we often see here in the US, are people who have had that claim verified by an international body. So it could be the UN High Commissioner or the Red Cross, and approved by the Department of Homeland Security. You can see that the majority of displaced people are women and girls, and a large proportion are actually children who are overrepresented. When we talk about asylum claims, asylum seekers are people who have that same well-founded fear, except they are now no longer, they might be in their country of origin still, or they haven't had their claim adjudicated by an international body. So they are waiting to have their claim heard. And here's where we're number one. The United States has the world's largest recipient of asylum claims. And you can see that compared to the last time this report came out, it has increased 4 times. And there are millions waiting for a decision on their claims, because that's what will decide if they're a refugee claimant and a successful refugee, or if they now become undocumented or displaced again back to their home countries. One thing I keep in mind every time I hear this rhetoric and I hear conversations is that nobody is waking up in the morning and saying, I'm choosing to be a refugee today. I'm choosing to be an asylum seeker today. Those decisions are placed on them by forces beyond their control, typically political decisions that don't involve them. But now we are also seeing climate. We're seeing people seeking asylum and refuge from the climate, and natural disasters as well. When we talk about immigrants in the United States, now again, you might say, Dr. Suleman, you just said migrants, now you're saying immigrants. In a lot of the literature in the US, immigrants and migrants are used interchangeably, but you can see that about 1 in 8 every US residents, people living in the US, are foreign born. And there are a large number of countries that make this up, the largest being Mexico alone. Another 25% comes from a lot of Asia, and then almost the majority come from a smattering of other countries. But let's talk a little bit about how people get to the US as refugees. We know if you're coming as a permanent resident, you submit an application, your application is accepted, and you enter with permanent residency. But what about as a refugee? There are several ways that people come. The first is option A, which I described. These are resettled refugees whose status was granted before arrival. In Canada, it's a very similar process, and this is how my family came to Canada originally as refugees. But what we see a lot of are options B and C and D. In option B, people come to the US on any kind of visa. It might be a visitor visa, it might be a student visa. And once they're in the US, they apply for asylum. They then have to have an interview with USCIS, and that asylum is either granted or denied. What we hear about at the border is a lot of option C, that people who are arriving at the US border and on arrival are requesting asylum. These individuals are transported into immigration detention, where they have this credible fear interview, and then again, a hearing that decides if they're granted asylum or if they're deported. And lastly, there are people who have come here on different visas, a tourist or student visa. At the time, they did not request asylum, but when their visa expires or they're overstaying their visa, then they are requesting asylum at that time. And again, they have to go for a hearing. So you can see that a hearing is essential in all of these pathways for people who have not requested, who have not been approved prior to coming. The number of refugees, resettled refugees, is exceedingly small. It's about 30,000 a year in the US. Those families get support for 90 days from the Office of Refugee Resettlement. Financial support, it's $1,500 per person. And then after that, they're sort of left on their own. So there's a lot we can talk about in terms of what we can do better for both resettled refugees. And certainly I know most people are familiar with what is happening at the southern border in terms of options C particularly. But what do immigrants look like or migrants look like here in the counties that we serve? And again, I'll show you this very briefly, but you can see the majority are Asian or Latino. And for those who are considered immigrants, you can see in Santa Clara County, it's a large proportion are identifying as Asian. But when we look at undocumented migrants, we see that we have about an equal split between Asian and Latino individuals who are undocumented, which means that we may not be able to always identify who is a migrant. And that's really important that we keep that in our minds. In San Mateo County, which is the other county that we often serve, it's a little bit different, but not too different. You can again see that there's a large breakdown of people who identify as Asian and Latino as primarily making up the bulk of immigrants. But when we break it down into who's an undocumented immigrant, you see a larger proportion of people who identify as Latino. And as I said, immigrants are not monolithic. Even though we use the word immigrant here to mean all migrants in the US, it includes a diversity of statuses. And what's important is that we recognize that status can determine access to resources, both federal and state resources, as well as in the community, because certain community organizations are set up to serve different statuses. And again, this is an example of people arriving from Afghanistan. And you can see, again, I'm not going to go into this in detail, but you can see that if you come as a resettled refugee, you're available to get a green card immediately. Refugees, if you're an SIV, you can receive a green card immediately. If you're a refugee, it's after 1 year, but both can get citizenship after 5 years. If you're a parolee, it depends on if your SIV application is approved. And if you come in any other status, such as seeking asylum on arriving here, all those other options I just declared for you, you can see it's really quite different federally. Now, what I'm going to tell you about as we go through the presentation are what are the rules here in California, because we're quite lucky to live in a state that has a much more inclusive policy and some really exciting policy changes that have come through recently. When we're caring for people who come to the US, recognizing they're coming from a variety of different countries, it's important that we recognize globally there are gaps in women's and birthing people and children's health globally. And this is just a set of indicators from the WHO that shows that for example, when we look at family planning, only 50% coverage. If you look at exclusive breastfeeding, again, it's only 50% coverage. But even when you look at the number of pregnant people who are living with HIV, it's only 75%. So again, it just highlights to us some of the conditions that we might be thinking about when they're coming into our care. When people come into our care, it's important that we stop and recognize that everyone may have a different experience and expectation of the health and social system. Even for me, coming from Canada, there were differences that I didn't expect and it took a little bit of time to get used to, despite all of the privilege and position and power that I have in understanding healthcare. For those that don't have that, it's important that we explain our personal roles. The word primary care or pediatrician or obstetrician may actually mean something different in different places. In many places, there aren't any APPs. They don't know what a PA is. They don't know what an NP is. And it's important that you explain what your role is rather than just the title. In other places, clinics don't have social workers and dietitians and discharge planners and nurses. They're not part of a clinical role in an outpatient setting. And so again, explaining what your role is and what you do, and before you do each step, why you do it. If I'm going to do an exam in the room for the first time, I say, it's important that I do your checkup now so I can understand if you're healthy. Is it okay if I do this? If I'm going to do screening blood work, I explain what that blood work is and why I'm doing it. For many people who are coming here, they have had, especially if they're coming as resettled refugees or asylum seekers, and particularly people without status, there may be a lot of mistrust with people who they see in positions of authority, like us as doctors. And so we have to earn that trust, and we can do that by being honest, warm, and forthcoming with what we do. Explain the concept of referrals, because in many parts of the world that doesn't apply. I had a patient that had congenital arthrogryposis who was from Syria as a Syrian refugee. And when they came to me, they thought I was the orthopedic surgeon, were very disappointed to find out that I was just a pediatrician. And when I explained I would refer them to an orthopedic surgeon and it was going to be a little while to wait, they thought it was because they were a refugee. They didn't understand that that was just the process that existed. Similarly with prescriptions, I've had to walk people to a pharmacy myself downstairs often and explain, this is the paper that you give to the pharmacist. You have to give your insurance, which is this card, and then they will give you the medicine back. And many people endorse frustration with our system. Despite many of the wonderful things it does, it's important that we validate that. There's lots of things in our system that are frustrating, and validating their experiences is very affirming. Another thing we can do is build a caring clinical environment. Things that we can do to make our care more trauma-informed is putting signage in English and Spanish and other languages that are common. As I shared, in both of our counties, we have diversity of who is a migrant. Recognizing that if everyone on the team is warm and welcoming and can answer questions about the clinic role, for example, explaining that you'll be able to get medical care here, and we also have someone who can help you with maybe finding food or other resources, and also explaining insurance and what that insurance does in a safe and non-judgmental way. Stanford does a wonderful job of ensuring access to high-quality interpreters. And we can also think about if there's written resources that you prepare for your families, make sure it's in multiple languages. I also like to use pictures because literacy levels vary around the world, and icons can be much more helpful. Thinking about making our physical spaces a little warmer and safer. And what we can do to help each other do that is promote a practice of reflective praxis as a team. What can we constantly be doing better? It may take many visits for you to complete what we call the first visit. There's a lot of information to get through, and you might not get all that information on the first visit. So what I do on my very first visit is I'm very welcoming. I say, thank you. I'm so glad to be your doctor. I'm really excited to help take care of you. What is it that I can help you with first? And often families have a particular need. Maybe it's immunizations, maybe it's prenatal care, maybe it's pain or some sort of condition. Focus on their needs first. And then I might say, since it's the first time I'm getting to know you, I need to ask a little bit more so I can better understand you. Is that okay if I ask you a few more questions? Recognizing it takes time to explore trust and explore sensitive topics. So especially for the teenagers that I see, I might defer what we call a heads or a confidential history for the next visit. I might also defer a gynecological exam for the next visit unless it's centered on their need. Things that I consider, and you can start to see, oh my gosh, this is a lot, which is why I don't do it all in one visit. Immunization records. If you don't have records in the people that you are treating, re-immunize when it's safe, recognizing, I know that everyone here knows you can't do rubella and varicella during pregnancy. I really like to get a handle on infectious diseases, which I will share with you an approach in a moment, but also think about hereditary conditions based on ancestry. One thing that we may not always be thinking about is environmental exposures. So for example, as I'll share with you a little bit more, women from Afghanistan have extremely high levels of lead because of contaminated water, particularly from shrapnel. And I've seen children that have a lot of shrapnel hidden and buried in legs, which is important if you're doing imaging. Also thinking about contaminated water as well as other vectors of disease. Family history, in terms of that, I always ask about consanguinity, again, in a non-judgmental way. I just say, are you and your partner related in any way except through marriage or except through your relationship? And in many parts of the world, it's very honest to say, yes, we actually have the same grandmother. And that's very helpful for you. In terms of immigration history, I do like to know when and how they arrived. And I might do this by saying, wow, welcome. When did you arrive? How was your journey? How has it been coming here? How were you able to come to the United States? Oh, I'm so sorry, that must have been so difficult. Where do you consider home? And did you have to go through any other countries to come here? All of this helps me know how to tailor their support and also know what their exposures are. When I'm thinking about nutrition, I like to think about access to food pre and post migration, because you might, if you miss the pre, you might miss some existing micronutrient deficiencies. I once had a child who came in with profound anemia, who was a refugee from Syria. And on history, it was actually because before arriving, they used to eat 3 kilos of yogurt a day, as that was the only food they had. And that was what was driving their anemia. Lastly, a social history is really important, as you can see here, and we'll go through some of this in a little bit. I do recognize that migration is a trauma, and so I don't pry into the trauma in a lot of detail, but as they're telling me about what brought them to the US, what some of the challenges were, I'm already recognizing, okay, there's definitely some trauma here that may be influencing some of their ability to access other things. Screening labs that I would do on everyone, and this may be helpful for those of you who are seeing patients for the first time as primary care, I would do these typical screening labs to look for anemia, to look for nutritional deficiencies, which I will share with you the prevalence in a moment. Depending on ancestry, I'll do a hemoglobin electrophoresis. I'll look for lead levels, as elevated blood lead levels are very high worldwide. And especially in pregnant people, we know that elevated blood lead levels can have profound harm on the fetus. I will do serological testing for most of these sexually transmitted infections, even in children, because prenatal testing is not available worldwide. And if they have a uterus, I will do a urine pregnancy test. I will also do a stool, ova, and parasites for parasitology. You'll be surprised what you can find in asymptomatic folks. And most people coming from the global south have no issue providing a stool sample for parasites, as that's quite commonplace. Things that I might consider depending on context would be strongyloides immunoglobulin. This is for anyone who's been in crowded conditions, certainly for people coming from Central Latin America. If the immunoglobulin is positive, it means you treat, and it's treated with 1 dose of praziquantel. Schistosomiasis is similarly treated, and it's just an immunoglobulin test if they're coming from African countries, and if they're coming from areas where malaria is endemic, either as their country of origin or in transit, I will also do thick and thin smears. You'll see here that I write serological testing for immunity if over 18. This is because the school system in California does not often accept titers as proof of immunity. So if they are under 18 and going to school, I will just re-immunize, but what you can do is actually test for serologies as well. I did mention infectious diseases, and I want you to see that it needs to be tailored to the country of origin as well as the migration journey. Just as an example, we can see how we might screen for someone coming from Afghanistan, coming from Guatemala. In Afghanistan, wild-type polio is endemic, and there's high rates of measles as well as other vaccine-preventable diseases. They also have high rates of TB. Malaria is quite seasonal. You can see a number of other diarrheal diseases, hepatitis A and B are prevalent, and congenital infections are really quite prevalent. Versus for someone coming from Guatemala, again, you see some parasites, you see tuberculosis as well, but you also see some other vectors that are not as prevalent in Afghanistan. So I actually use the CDC. I'll type in CDC country of origin, and it'll tell me all the things I have to look for every single person that I'm seeing in my clinic. Other screening needs to be tailored to ancestry and exposures. So, for example, we see, again, in Afghanistan, we have a high prevalence of anemia, but hemoglobinopathies are more prevalent, versus in Guatemala, it's mostly nutritional. You also have iodine deficiency in Afghanistan, which you don't usually see in Guatemala. You'll see malnutrition as well as overnutrition. And then congenital disorders in Afghanistan are quite high because of the high rates of consanguinity. When it comes to menstruation and conception, it's important to recognize that menstruation is still stigmatized in some areas of the world and may be leading to unsafe hygiene practices. So again, maybe not on the first visit, but on the second visit, you can say, it's important for me to understand your menstrual health. Help me understand and go through your typical questions, but also ask what do they do for menstruation during that time. See if they have access to safe sanitary pads and other oh my goodness, hygiene, menstrual hygiene. With respect to contraception, there is data that shows that immigrant women, using the term immigrant broadly to include all migrants in high-income countries like the US, they use less effective contraception. And some of the reasons that have been reported is that they've had negative experiences with counseling, they have limited partner support, and healthcare providers have had difficulty adapting care with language as well as cultural differences. But one thing that can help facilitate uptake is using visual tools and working directly with migrant families, women and people with uteruses, as well as their trusted community partners, to adapt how we should do the education and counseling best. I would be remiss if we were talking to OB-GYNs about caring for newcomers, and we did not mention female genital mutilation. As many of you know, it is a prevalent practice globally, although there are more and more bans coming in around the world. It is mostly practiced in sub-Saharan Africa, as well as Asia and the Middle East. I will ask families about female genital cutting. I don't use the word mutilation, as that is not widely understood. And I will find, again, if I ask about it in a non-judgmental way, has anyone in your family, in your community, talked about doing some genital cutting? And often I will hear from women, particularly women who are fleeing with their daughters, saying that was the reason that they fled their country, because they didn't want their daughter to have genital cutting. But if that is something that is identified, I would certainly be referring to you, as you know that there are 4 types of different kinds of genital cutting. But here in the US, it is banned. And there are a number of sequelae, both for the person, but as well as infection, and in terms of childbirth, as well as menstruation, that again, I'm sure all of the folks here in this room are well aware of. Like I said, we also want to think about prevalent non-communicable diseases. So anemia is really quite elevated around the world in pregnant people, as well as people who identify as women. And many of them have elevated blood lead levels. It's actually also been associated, in addition to environmental exposures, with the use of kajal, which is a black eyeliner, or a black it's an eyeliner made of charcoal. And the reason we use it is, reason many communities use it is to ward off the evil eye. And you know, a way that you can kind of have a conversation around this. I once had a baby in my practice who had a congenital disorder and also elevated blood lead levels when she came in. And you know, I said, I also don't want your baby to have the evil eye. Here's another pencil you can use instead that's safer for her, one that didn't contain lead. We also said, what about if you put the black mark behind her ear, or a black thread on her wrist? Something, again, that keeps the evil eye away. And that's an example of working together with families, that you're recognizing their cultural importance and finding safer harm reduction ways to address them. Nutrition concerns, like I said, are extremely prevalent. There are high rates of micronutrient deficiencies that we might not see here, like vitamin A, for example. And there's a double burden of over and under nutrition. So you might see people who are malnourished, but you might also see people who have overnutrition. As you can expect, refugees and asylum seekers have much higher rates of depression, anxiety, and post-traumatic stress disorder. And particularly youth, women, and people identifying as LGBTQ are at a higher risk of gender-based violence as well as trafficking. I've had a number of families in my clinic, both in Canada and here, who have been victims of human trafficking, most of them women, but not always. And so it's important that we make sure that we're screening for mental health in a sensitive and compassionate way. I don't even use the word mental health because that carries stigma, but I might ask how they're feeling. So I might say, how's your heart feeling? How is your mind feeling? Do you have any sadness? And then ask about the physical manifestations of mental health. There are a number of validated tools. The one that I quite like is the Refugee Health Screener. It's written, I think, in about 15 different languages. And what I like about it is it's two parts. One part is a series of questions that can be scored. The other part is simply a thermometer, and people can simply indicate on the thermometer what their level of distress is. And if it's above a 5, it's considered valid and need for further intervention. Postpartum depression in immigrant mothers who have come to the US are quite high. Globally, we know it's about 20%, but prevalence rates are actually anywhere from 20 to 40%. And again, the factors that might contribute are not going to surprise you. It's isolation, it's a lack of social support. And one that may be more unique is that this challenge that many people coming from different cultural backgrounds might have between the cultural expectations we have for new parents here in the US versus their cultural influences. And that tension can contribute to more distress. So in summary, these are some ways that you can, again, make your clinical care more supportive for newcomer families. You can use this trauma-informed approach that we've described. You can try and minimize barriers, for example, by having interpretation, maybe thinking about flexibility with appointments, maybe thinking about timing. I know we don't always do this in our institutions, but I feel like these are opportunities for us to do this even better. Thinking about navigation as well as social support, and making sure our care is culturally safe, not culturally competent, but rather how can we think about safety that is recognizing that I can't be culturally competent in all cultures, but I can be safe. So it's a respectful engagement. It's striving to address the power imbalance, and it's trying to eliminate racism and discrimination. And so the factors that contribute to culturally safe care is self-determination, having people be able to determine their own care, participate in decision-making, respect and protection of culture, and equity and non-discrimination. As we know, the health of our families is well beyond the clinic walls. We know that our biology makes up a very small proportion, and that much of our health is dependent on our social determinants and our access to care. And all of these, the other thing I'd like us to remember is that what we see in terms of these health disparities and problems are really just the leaves of the branches of a tree that are rooted in structural causes. We know that we might see depression, and that might be triggered because of a lack of social connections and a lack of substance use. And that might also be facilitated by our social environment. But if we look at the root causes of health, we know that a lot of our disparities are rooted in racism, in xenophobia, in prejudice, in patriarchy. And it's important that we name that as we move to address health disparities, because if you can't name the problem, you can't solve it. These are some of the social factors that contribute to healthy resettlement: having social support, having health insurance, having legal support, having access to nutritious food and safe housing, having adequate income, being able to communicate, and also being supported to retain your own cultural identity while being able to integrate into your new host country. So let's talk about how we can address and support these social factors in the patients that you see. The first thing that's important to know is that many people are not accessing public benefits because they are worried that it will be considered what is called a public charge. And for those that don't know, a public charge is what the government says is a cost that you're incurring that will affect your immigration status. However, many public benefits are not included in this rule, which includes healthcare, Medicaid. It includes nutritional programs, public housing, and workers' rights, including income tax credits. And it's important that we as providers know this because we are looked to as a person who can be trusted. And if we can share this information authentically with our families, we're also more likely to have families be able to access the very benefits that they deserve and are entitled to, which will improve their health. For many of you caring for pregnant people as well as their newborns, let's try and ensure that we can help them enroll in these two nutrition programs. The Women, Infant, and Children program is available to anyone who's pregnant, breastfeeding, or has a child under the age of 5, regardless of immigration status. There is lots of data that this improves lifetime health, but some recent studies came out that showed that only half of those who are eligible are being enrolled. And again, the causes are often a fear that this will contribute to public charge, not knowing how, and not knowing about the program. CalFresh is California's answer to SNAP. It does require that someone in the household be a citizen or permanent resident, but that person can be a newborn. So as soon as families have a newborn, that household now becomes eligible. And recent data from the Public Policy Institute of California showed that 50% of newborns are being enrolled after the first 3 months of life, and a third are not being enrolled in all. So strategies that help newborns enroll in CalFresh will actually help the whole household because that whole household can benefit from these nutrition programs. Home visiting programs can also provide critical social support. These are 2 programs available in Santa Clara and San Mateo County, where they can receive free home visiting support with no immigration requirement, and again, not considered public charge. And I put both phone numbers here as well as eligibility for you. And most excitingly, did you know that as of January 1st, 2024, anyone is eligible for Medi-Cal? Prior to that, it was only for people who were up to the age of 26 and over the age of 50. But since January 1st, we have closed that gap. And that means they can now get full Medi-Cal if they meet the other income limits, regardless of immigration status. This includes physical, dental, and mental health. And much data is showing that people who are eligible are not enrolling. A lot of the reason is worry about public charge and not knowing how. And so in the absence of having an enrollment specialist in clinic, another way that I've been doing this is actually printing out a map, telling a family, go here, and I write a letter to go along with it that says, please help this person enroll in Health Plan of San Mateo, or a script for the family to saying, please help me enroll in the Health Plan of San Mateo if they're in San Mateo County or in the Santa Clara Valley Health Plan. But improving our care for newcomer families needs advocacy across the spectrum. And I know a lot of you do this at the patient level, but I'd invite you to think about one way that you can extend your advocacy to the next level. What's something that you can do at the institutional level, or at the community level, or at the state and federal level? All of the work we do, and what must be central to our approach, is working with the families that we support. There's a phrase, nothing about us without us is for us. This comes from disability justice advocates, and it applies to the work that we do. And so in order to make care better for newcomer patients, we need to work with and alongside them. And I'm going to share with you some examples of how I've done this in the past that hopefully will be inspiring for you to think about ways in which you can do this. Nicole had mentioned the Compass Clinic, which is a clinic that I was able to create in Canada that is a trauma-informed and low-barrier clinic for children with special healthcare needs. This came about because of direct conversation with families, as well as refugee settlement agencies and primary care places that said, you know, it's fine if someone comes in who's healthy, we got it, but once they have an extra need, this is what we need. And we worked through working with the family as well as through the literature. We've identified these 6 important facets, which I've also shared with you, are ideal when we're providing trauma-informed care. We have long appointments, we have a navigator, we have making sure that every provider in that clinic is trained in cultural safety. We have a lot of access to interpreters, and we translate our resources in the top 5 languages. And we try as much as possible to promote family-centered care, as well as having an enhanced understanding of our insurance status. Because in Canada, contrary to public opinion, it's actually not that different from America, in that if you only qualify for our provincially funded healthcare if you're a permanent resident or a Canadian citizen. Unlike California, that has this wonderful Medicaid expansion, in Canada, if you're an asylum seeker, you get access to a different kind of funding that is much more narrow and not everyone has to accept. And if you're undocumented, you get nothing. And we learned, again, through some of my work, that in the patients that I was seeing, we did a qualitative study recognizing that it was very difficult for people who are asylum seekers and undocumented to navigate the healthcare system. They were asking their settlement providers who had no idea. The healthcare providers thought the settlement providers knew. And working with a team of 7 youth who are listed here, who are all paid, they represented 4 different languages, and they included youth with disabilities. We got a grant to co-design an intervention, which turned into this toolkit. This toolkit has actually been shared with federal agencies in Canada, and it's changed what's been covered for some youth. We're going to be doing a national webinar and distributing this nationally, as well as digitizing and translating this into multiple languages. And most recently, I'm doing this again here with an MCHRI grant that I have from San Mateo County, working with undocumented, unaccompanied youth. We've got 9 youth who are all paid and have some really powerful stories. But you can also do this in traditional research design. So this was my new investigator grant that I got from the Canadian Institute of Health Research, which is our NIH equivalent. And we're working with a team of parents to create inclusive guidelines for how to better include newcomer families in research, and co-design from start to finish a cohort study that will look at growth and nutrition trajectories once children arrive in Canada. And I'd love to do this here too. So if you're interested in working with doing community engaged research or learning how to incorporate community advisory boards into your research, stay tuned. We've got some MCHRI sessions coming up led by yours truly, and I'd love to talk with you more about that. All of these partnerships have been bi-directional. So all of the people who have, all the youth, as well as the parents who are part of these studies, we extend opportunities beyond the study. So I've, for example, if I give a talk and I will ask in lieu of a honorarium for myself, is there a way that it can benefit the youth on my team? I've been able to connect them with other educational programs. We make sure that they co-own everything. So they have full ownership of all the materials. They can do whatever they want. And we've invited them to present at conferences and meetings and presentations. And like I said, everyone is compensated. Our Voices as Physicians Matter. This is from a press conference I did in Canada when during COVID, they were unrolling a rule that allowed families who were undocumented to get care in the clinic. And actually in this picture, the woman in blonde hair behind me is the parent of one of my patients who was actually at this rally, and this child has special needs. While I was talking, she was shouting, "That's my doctor." She was so happy to see that her doctor was at a cause that she cared about, and standing alongside our patients can go a really long way. So like I said, I hope you have developed what I call this clear approach, where centered is community. We value lived experiences, and we combine this with our advocacy, research, and clinical care to provide the best possible care for our families, recognizing that care is rooted in the community, not just in our institutions, recognizing that advocacy and research can take many forms, are not distinct, and a community should be part of both. So I invite all of you to think about one way in which you can take a clear approach to caring for newcomers. What's one thing you can do differently in your clinical care? How else can you include people with lived experiences in your work? How can you amplify newcomer voices? And how can newcomer communities be involved in your research? These are some of the take-home points. Again, I hope you've understood that there's no one process of migration, that it's important to tailor your assessment. There are a number of services that families are eligible for, and I think you can actually go a long way in helping families connect to these programs and consider ways to include people with lived experiences in the work that we do. I did want to share some resources with you. So there's a toolkit from the AAP. It is centered on child and youth health, but I think much of it will still be quite helpful to those folks in the room. I find the CDC Immigrant and Refugee Migrant Health page quite helpful. Like I said, if someone's coming from a certain country, I just put in CDC country and I'll see what are the things I need to screen for. This is a Canadian tool, but it has checklists based on where people have come from globally that you can download and print, which are also quite helpful. And then here are a number of social services that you might want to keep in mind. There are two agencies that I direct people to who need immigration support. If they're in San Mateo County, it's the Libre Project. If they're in Santa Clara, it's Siren. KeepingYourBenefits.org is a great tool. So you can also tell families if they're worried, they can check. And there are ways in which you can support CalFresh and WIC enrollment. There's also a lot of people with lived good experiences caring for newcomers within your department. I specifically want to note, Kay Daniels and the work that she does with the families at the border, and ways in which you can support that work are another way that you can contribute. So I wanted to say thank you, particularly to the clinic, my lab, all of the community partners, and as well as folks in the Office of Child Health Equity. Here's the funding we've gotten for some of the research we've done. None of this funding has supported my time. It's all operational support. So thank you so much.